All right, welcome. In this deep dive, we're going to conduct a detailed academic overview of two distinct but related B-cell neoplasms, chronic lymphocytic leukemia and hairy cell leukemia. We'll really get into the weeds on their pathophysiology, how they present clinically, and how they're managed therapeutically.
So here's our roadmap for this session. We're going to start with a really comprehensive look at chronic lymphocytic leukemia. You'll hear me call it CLL, covering everything from its basic biology to treatment. Then, we'll pivot to a focused overview of hairy cell leukemia.
Okay, let's kick things off with the fundamental pathophysiology of CLL. Understanding where this disease comes from at the cellular level is absolutely critical to grasping everything else that follows.
Now, here's the most important distinction you need to make right away. CLL is not a disease of rapid proliferation like the acute leukemias. It's not about cells dividing out of control. Instead, the core problem, the central pathophysiologic mechanism, is a failure of programmed cell death, what we call apoptosis. The cell at fault is a naive B cell that's basically forgotten how to die, and when that happens, these immortal cells just accumulate.
So how does this all unfold? Well, it all begins with a single, normal, naive B cell. Then, a genetic hit causes a defect in its apoptosis pathway, allowing it to cheat death. This kicks off a clonal expansion where the cells start to express new surface markers, specifically CD5 and CD23. This early preclinical stage is something we call monoclonal B-cell lymphocytosis, or MBL. We only make the full clinical diagnosis of CLL when the absolute count of these clonal lymphocytes in the blood crosses a specific threshold, 5,000 per microliter.
Now this is a really critical concept to get your head around, the CLL/SLL continuum. Think of these as two manifestations of the exact same disease. The only real difference is where it's primarily located. When the disease is mostly in the peripheral blood and bone marrow, we call it CLL. But if it presents mainly with swollen lymph nodes, we classify it as small lymphocytic lymphoma, or SLL. The key takeaway? They are biologically identical and share the exact same immunophenotype.
Okay, so now that we've covered the what, let's talk about the how. How does CLL actually show up in a patient, and how do we diagnose this often subtle and slow-growing disease? Get this, and this really speaks to the sneaky nature of CLL. A whopping 80 to 85% of patients have zero symptoms when they're diagnosed. The discovery is almost always incidental. It just pops up on routine blood work that was done for some completely unrelated reason, maybe like a pre-op physical.
So who gets this disease? Well, the epidemiology gives us some crucial clues. The median age at diagnosis is 72, so this is very much a disease of the elderly. And there's a clear male predominance. What's really interesting etiologically is that CLL has the strongest familial inheritance pattern of all the leukemias. And here's a sharp contrast to other blood cancers like AML or CML. There is absolutely no established link to radiation exposure.
The first real clue often comes when you look at the blood under a microscope. The findings on the peripheral smear are pretty classic. What you'll see is just a sea of these small, mature-looking lymphocytes. We often call them small blue round lymphocytes. They have very little, pale cytoplasm and no granules. But the most characteristic finding, the real dead giveaway, is the presence of smudge cells.
So, what exactly is a smudge cell? Well, it's not a true cell type. It's more like a crime scene clue. See, the neoplastic lymphocytes in CLL are incredibly fragile. When you go to prepare a blood smear, the simple mechanical force of spreading the blood on the glass slide is enough to rupture many of these delicate cells. What's left behind are these nuclear remnants, and we call them smudge cells, seeing them as a true hallmark of the disease.
All right, so a diagnosis has been made. Now what? The next step is absolutely critical: risk stratification. In this section, we're going to cover how we figure out a patient's prognosis and, maybe most importantly, whether they need treatment right away or can be safely observed.
The Rye and B-Net staging systems are fundamental to how we manage CLL. As this simplified Rye table shows, there's a really important dividing line. Stage 0, which is just high lymphocyte count, and Stage 1, which adds lymphadenopathy, do not require treatment. This is what we call watchful waiting. But the second the disease progresses to involve the liver or spleen or causes anemia or low platelets, that's stages 2, 3, and 4, treatment is now indicated.
But clinical staging is just one piece of the puzzle. To get the full picture, we have to look deeper at the molecular and serological markers. On the good prognosis side, we have things like a 13q chromosomal deletion and what's called a hypermutated IgVA status. Conversely, signs of more aggressive disease include an unmutated IgVA status, high expression of a protein called ZAP70, and elevated serum levels of beta-2 microglobulin.
So this brings us to a really important question. For a disease that can just simmer along for years, what's the worst-case scenario? What's the most dangerous turn it can take? Well, the answer lies in a phenomenon known as Richter's transformation.
Richter's transformation is when CLL basically flips a switch and converts into a high-grade aggressive lymphoma, most often diffuse large B-cell lymphoma, or DLBCL. The clinical red flags are stark and sudden. A rapid increase in lymph node size, the new onset of B symptoms like fevers and night sweats, a skyrocketing LDH level, and lighting up on a PET scan. This is a true hematologic emergency.
Let's shift gears now and talk about treatment. We'll cover the specific indications for starting therapy and then walk through how treatment strategies have evolved, from the classic chemoimmunotherapy regimens to the modern targeted agents that have really changed the game.
Now remember, we don't treat every CLL patient the moment they're diagnosed. The indications to actually start therapy are very specific. We've already talked about advanced rise stage disease or suspected Richter's transformation. Other triggers would be severe B symptoms, a lymphocyte count that's doubling very quickly, or a related autoimmune hemolytic anemia that isn't responding to steroids.
For decades, chemoimmunotherapy was the frontline standard. The textbook gold standard regimen you'll read about is FCR. But here's the thing. It has a very high toxicity profile. It's really only suitable for a small group of young, fit patients. In the real world, the vast majority of our patients who are elderly and less fit receive the BR regimen. Bendamustine and rituximab is just tolerated much better, and it's become the most commonly used regimen in practice.
But this is where the story gets really exciting. The whole treatment landscape for CLL has been revolutionized by targeted oral therapies. For relapse disease, we have incredible options. Ibrutinib inhibits a key signaling molecule called Bruton's tyrosine kinase. Then there's venetoclax, a BCL2 inhibitor, which is just fascinating because it directly attacks the core problem in CLL. It reteaches the cells how to undergo apoptosis. We also have PI3K inhibitors like idelalisib. And these drugs are so effective and well-tolerated that they're now being used more and more as first-line options, especially in those non-fit patients.
All right, let's make a hard pivot now to our second topic, hairy cell leukemia, or HCL. Now, while this is also a low-grade B-cell neoplasm, I want to be clear that it's a totally separate and distinct entity with its own unique biology, presentation, and treatment approach.
What's amazing about HCL is how precisely we can define it at a molecular level. It comes from a memory B cell, which right away distinguishes it from CLL's naive B cell origin. And its pathogenesis is driven by a single, near-universal driver mutation, BRAF V600E. This mutation is what gives the cells their characteristic appearance, those fine, hairy cytoplasmic projections that give the disease its name.
HCL has a really unique clinical and pathological fingerprint. The classic clinical presentation is a triad of pancytopenia, massive splenomegaly, and, very uniquely, monocytopenia, a low monocyte count. This lack of monocytes puts patients at high risk for opportunistic infections. The immunophenotype is also distinct, with markers you don't typically see like CD11C and CD103. And if you look at a bone marrow biopsy, you'll see cells with a classic fried egg appearance, and often a lot of fibrosis.
And the good news is we have incredibly effective treatments for HCL. The first-line drug of choice is cladribine. It's a purine nucleoside analog that can induce very durable, long-term remissions, often after just a single course of therapy. For the rare patient who relapses, we have vemurafenib, which is a BRAF inhibitor that directly targets that V600E mutation that's driving the whole disease.
So I want to leave you with this final big picture question. Diseases like HCL, which are defined by a single targetable mutation, they might just be a glimpse into the future. As our understanding of molecular drivers gets deeper and deeper, are we going to move away from these old classifications based on how a cell looks or where it is in the body, and instead start reclassifying cancers based on their core genetic vulnerabilities? It's a question that is absolutely going to shape the future of this field.